Good morning. Good morning. I was given instructions to say that I am Dr. Valerie Montgomery Rice, and I should spell my last name, Montgomery, space, no hyphen, Rice, R-I-C-E. And I am the president and dean at Morehouse School of Medicine. I am so excited to see all of you all here who are as interested as we are about mental health, because we know that that correlates with the health of the nation. At Morehouse School of Medicine, we understand and have always understood that the health status and health behaviors are determined by personal, institutional, environmental, and policy influences. So you can see why we're here today, because we understand that what we do in the space of health policy is really going to impact the mental health environment. We've always talked about health disparities, but as I often tell people, we don't need to catalog another health disparity. What we really have to begin to have a conversation about is, how do we achieve health equity? And there's no greater place or space that we need to achieve health equity than in mental health. Health equity for all sectors of the population is at the heart of what we are trying to achieve at Morehouse School of Medicine. So it is very much fitting for us to stand here with Bill and the Kennedy Forum, sharing the excitement of joining forces to announce the creation of the Kennedy Center for Mental Health Policy and Research at Morehouse School of Medicine. This collaborative partnership will increase the visibility of mental health policy issues and solutions by engaging the public and policymakers and what we describe at Morehouse School of Medicine so intimately, the community. We cannot do this without the engagement of the community. That community will not have borders. That community will not be defined by race and ethnicity. That community will not be defined by where people live, what zip code they happen to reside in. That community will be broad and it will be inclusive, because we understand that that's the only way you get to promote health equity. Now, we're not talking about health equality. We're not talking about just making sure that access is available for people who have mental diseases. What we're talking about is doing the appropriate assessments, screening, early diagnosis, taking that information that is gathered already out in the public sector and integrating it into a way that policy is developed, that disseminates to those borderless communities. Together, we plan to ensure that behavior and mental health remains at the forefront of the national discourse on the healthcare standards and coverage. And there's no better place than we can think of at Morehouse School of Medicine than in our Satcher Health Leadership Institute that is still under the direction of the renowned Dr. David Satcher, the 16th Surgeon General and the former director of the CDC. He will be the nucleus of the new partnership in conjunction with the leadership of Patrick Kennedy and others at the Kennedy Forum. So today I stand here given the unconditional full support of Morehouse School of Medicine in my capacity as president and dean, such that the world knows that we are excited, we are committed, and we stand ever vigilant to advance equity in mental health and behavior health in America. At this time, I will bring up my partner, Bill Emmett, who will give comments on behalf of the Kennedy Forum. Thank you.
Thank you, Dr. Montgomery Rice.
Did you spell your name?
I'll spell my name. It is E-M-M-E-T with just one T, which is a common mistake. But I speak for the entire Kennedy Forum team. That it's just the most exciting thing we can imagine to be working with you, the Morehouse School of Medicine team, Dr. Satcher, and so many people that we've met over the past several months as we've been forming this partnership. And this partnership really is all about collaboration. It's collaboration, as Dr. Montgomery Rice talked about, is about community, and it's about community moving forward together. It's really all about all of us. So working together towards a common set of goals will help us all in the mental health and addiction fields to make real progress on a range of policy issues and political issues, critical issues, that have to do with everything from full implementation of the parity law to leveraging the technologies that are out there available to us today to really better understand these disorders and how to treat them. You'll hear more about various parts of the research that we're going to be doing over the coming months from Dr. Satcher, from Patrick, as we get into the heart of this program. But I'll say that we're looking at both provider accountability and payer accountability. So while we want to make sure that parity is implemented, we also want to make sure that quality care and outcomes are at the fore. It's just one without the other just doesn't make sense. So it's not a stretch to say that today we have an ambitious program, so I don't want to stand in the way of it for much longer. But we have come so far, and we've got so much progress to make that our collaboration is very, very important. There's so many people in this room. I think it doesn't make sense really for me to begin to acknowledge everyone who's here, but I can just say to all the leaders of the many organizations who are here, we're so grateful to you for coming. And to the people who are watching this webcast, including many people who I think intended to be here, but because of the weather in the Northeast couldn't, we're very grateful to you too for tuning in. So I think now we'll move to the program. It's really my honor to introduce our moderator for today, someone who is no stranger to the National Press Club, that's for sure, and to many of you. Cece Connolly spent 25 years as a reporter for the Washington Post covering politics and healthcare. Today, she's the managing director of PricewaterhouseCoopers Health Research Institute, leading a national thought leadership and research initiatives for a range of organizations. We're delighted that Cece can add her expertise and her skills to moderating today's panel. And so with that, I will turn it over to Cece Connolly. Thank you, Cece.
Well, good morning, everyone. Thank you, Bill. Thank you, Dr. Montgomery Rice. I'm CECI. It's usually the one people have trouble with. It's a real honor and pleasure for me to be up here, and in particular to be with our two special guests who are going to join me here in just a minute. And the framing for this morning's discussion, as you all know, very timely, the State of the Union in Mental Health and Addiction. And I thought I might just take one moment and provide a couple of statistics for context for this conversation, because they really are quite startling, and I think maybe we tend to forget them. The number of suicides each year in this country, 38,000, and that is a number that's been rising, not falling, even as things such as homicides have been coming down. 6 million children in our nation today have emotional, behavioral, or developmental problems. 2 million people with mental illness are in jails or prisons in the United States. Now, these are not just statistics, they're real people, and there's real money at stake. Think about the impact of mental health on our society. Direct and indirect costs today are about $444 billion. And even in a town like Washington, that's real money. We see it in our Medicare and Medicaid budgets that continue to rise. We all see it in our own health insurance premiums, which continue to go up each year. We see it in the burden on local budgets, whether it's schools or Medicaid. We see it in employer costs, particularly around absenteeism or something known as presenteeism, which we'll talk a little bit about today as well. Now, unfortunately, this is not new. Part of the reason that we're here today is this week is the 52nd year anniversary of an incredible speech given by Patrick's uncle, President Kennedy, on mental health. 52 years ago this week. 19 years ago, Dr. Satcher, as Surgeon General, put out a landmark Surgeon General's report on mental health. And yet we're still here having this conversation. So maybe it's a little bit better late than never, but I'm glad that we are here today to tell you a little bit about this exciting partnership and the two leaders of these organizations. We're going to bring them up, have a conversation, and we're going to invite all of you to join in as well. So thank you, and gentlemen. So these two have been doing television interviews since about 5:30 in the morning, right? So they're either fully awake by now or ready for a nap. I'm not sure which, but this is such a hot topic. You've been talking for hours to TV reporters all over the country. But for those of us who just got up, let's start a little bit. Just the two of you have been at this issue for a long, long time, probably all of your adult lives, I would say. Tell me a little bit about why this particular issue and how you two came together. Patrick, do you want to start?
Yes, thank you very much for moderating, Cece. And I just say Dr. Satcher is a real hero of mine, and for many in this room who know of his work, he really laid the foundation for the parity law, which I was honored to be one of the sponsors of with his Surgeon General's report. It really talked about mental illness being a physical illness, talking about the fact that it could be identified and treated effectively, which of course is the big challenge we have, is getting that message across that there are real treatments and they do work for those suffering from mental illness and substance use disorders. So I just thought it was appropriate that we take the foremost leader in mental health public policy with his landmark Surgeon General's report and really work to get that message out there, because I think that's the issue we have, is translating what we know into practice. And that's what I hope that we are able to do with the work we're doing together going forward.
Dr. Satcher, what brought you to this partnership and what's your vision for it?
Well, you know, as Surgeon General, you can issue reports, but it takes somebody to lead in Congress. And I was really fortunate when I met Patrick Kennedy. I already knew his father, Senator Ted Kennedy. They were a tremendous team. His father, of course, worked with us on childhood immunization and disparities in health. But when it came to issues related to mental health and addiction equity, Patrick was a leader in Congress, and we developed a great working relationship. It means a lot to me to be able to join him in this partnership so that we can continue to move this issue forward. I mean, we have a great opportunity. But opportunities are one thing. It was John Gardner who said life is full of golden opportunities, but they're often carefully disguised as irresolvable problems. So I'm delighted to be here today. Thank you.
We have billed this as a State of the Union briefing for everyone. So I'd like to get your perspectives, and I know that your partnership has already done some polling of the American public. So maybe you can share with us what you think the State of the Union is and what we've learned so far.
Well, the State of the Union is of enormous possibilities to absolutely transform healthcare so that it doesn't mean healthcare and mental health care. It means healthcare which includes mental health care as integral to the delivery of overall healthcare. That is our possibility. It's also our challenge, because historically we've separated the treatment of mental health and overall health, and it's really been to the detriment of the patient. And frankly, as you know, at PricewaterhouseCoopers, to the bottom line. And the bottom line shows that we more effectively get overall healthcare costs reduced dramatically if we integrate the treatment of mental health and overall health. So what we're talking about here is not just mental health for those with a primary diagnosis of mental illness or substance use disorder. We're talking about mental health care for everybody, and obviously making sure that we treat those who are most distressed because it's a primary diagnosis and they don't get the treatment that their illness demands that they get.
But my impression, doctor, is that stigma continues to be such a barrier in this area to getting treatment.
Stigma is still a tremendous barrier. Stigma affects the individual and the individual's willingness to seek treatment or even to acknowledge that he or she needs it. Stigma affects the family and community in terms of how we look at people with mental disorders. And stigma affects policy, as we have demonstrated. If you have the right policy leadership, we can move forward. Stigma even affects healthcare providers and how we approach patients. We're trying to change that, and I think part of the opportunity which we have in integrating mental health and primary care, and we're doing that in 10 community health centers and in the emergency room at Grady, which is one of the largest public hospitals in the country. We've got to treat people as whole persons. The brain is not only a part of the whole overall body, it is probably the most critical part, the most critical organ. And so we can no longer separate that in our thinking. So in the community health centers where we work, in the emergency room, we treat people as people, and we try to make sure whatever their concerns or need, we respond to those.
You mentioned Grady, and I'd love for you to share with the audience a little bit about the project that you've had going on there for the past few years.
Yeah, I think Dr. Glenda Wren is in the audience, so I have to be very accurate about this. We actually started this program 3 or 4 years ago in Grady Hospital. We believed that there was something we could do to change what was going on in the emergency room. And people were running back and forth to the emergency room when they had a crisis, but not seeking mental health care generally. So we volunteered to take over mental health services in the emergency room. And over a period of years, we demonstrated we could improve the care of patients by decreasing waiting time by 80%, decreasing the need for using restraints by at least 70%. And what I think got most attention, we actually reduced costs by 40%. Many of these patients ended up in continuity of care relationships in our community health centers and community mental health centers. And so we feel very good about that. We have a lot to do. As Patrick says, we have these great policies in place which can expand access. They can improve preventive services. They can also make sure that pre-existing conditions are not barriers. So we're trying to do all of those things, but it's critical that we continue to move forward.
I want to get to a couple of those laws that you just mentioned and some of the elements, but before that, Patrick, you mentioned this sense that there's great possibility and attitudes of Americans. Elaborate a little bit more on what you're seeing.
Well, we have the combination of what we know to be better than ever before. As you just heard Dr. Satcher, the evidence is in. This is not soft science, it's hard science. Now the question is, are we going to effectuate it? Take what we know and implement it. But the thing I think is going to drive this change is the passion that we have for our American heroes, those returning from Iraq and Afghanistan who are suffering from the signature wounds of war, which are often referred to as invisible. That's kind of a stigmatizing way of describing something that's biological, physiological, that you can see on x-rays, and yet we refer to it as invisible. Misnomer of all sorts. So I believe 72% of our Iraq and Afghan war veterans are never going to go to the VA in their lifetime. 72%. Most people don't know that. They think that all veterans who have needs go to the VA. What we know is that they're going to be covered by their employer-sponsored health care. That means our veterans are in the employment of every major American company and small businesses as well. So the parity law is for our patriots. In other words, effectively ensuring mental health is incorporated in the benefits afforded to those workers through their health plan is going to ensure that they do not get ignored because those types of benefits are not seen as equal to the rest of their physical health benefits. And that's where the parity law came into play, and why I think that the parity law is really the vehicle for us to get this message out there.
You mentioned the parity law. Of course, the other important piece of healthcare legislation coming up on the 5-year anniversary of the Affordable Care Act, thanks in no small measure to your father and his work. But I gather that you have some concerns around enforcement and implementation of these two laws. And share a little bit what your concerns are.
Well, every family that's had anyone who sought a mental health or substance use disorder care knows that what is the law doesn't often get translated into what's in practice. So the promise is there, the practice isn't. We need to monitor the implementation of the law, and to do that, we need full disclosure by the insurance carriers who are charged with delivering, in most cases, public dollars, to ensure that those public dollars have a fiduciary responsibility to the American people, which means that if we spend the money for this, that we're sure that we're getting what we pay for. And that means that they do not erect any higher limitations on the delivery of care if it comes to a mental health or substance use disorder case when compared, hence the word parity, to medical and surgical care. If we don't have the disclosure data that allows us to make those comparisons, we're not going to be able to determine whether the person with depression is treated the same way as someone with diabetes. As Dr. Satcher said, the key to the reduction of the burden is to treat these illnesses as chronic illnesses and not wait for them to become acute illnesses, as Dr. Satcher mentioned, is the problem with a lot of emergency rooms and frankly, our jails in this country is because we've waited before we treat these illnesses as the illnesses that they are.
And it seems to me, Dr. Satcher, another important provision of the Affordable Care Act, of course, is the Medicaid expansion, which we are seeing in approximately half of the country. What does that patchwork expansion mean in terms of mental health of the nation?
You know, I have to say the Affordable Care Act is one of the greatest opportunities we have ever had and will have to expand access to mental health services to people in this country, access to preventive services, making sure that pre-existing conditions are not barriers. However, now that the Supreme Court has given states the option of expanding Medicaid, we are really concerned. I mean, Georgia has not yet agreed to expand. Florida, Texas, North Carolina, several states have not, and therefore millions of Americans who could have access to mental health services do not have it, and unless things change, will not have it. So we have a tremendous opportunity, but as Patrick said, we need implementation in every state in this country. It's really sad. I mean, when you think about what families go through, we just had last week in Atlanta a mother who committed suicide and then, killed her 3 children and then committed suicide. Another person who just walked out onto the freeway. You can go on and on with these stories. The fact of the matter is that this is real. People who need mental health care and don't get it are at risk. The communities are at risk. So I just don't see how we as a nation can be satisfied until we, in fact, have fully implemented the Mental Health Parity and Addiction Equity Act, as well as the Affordable Care Act.
One of the things that's so striking listening to you both, even though you're focusing your comments on mental health, I'm hearing so much of the same dialogue that I have at every other healthcare gathering that I'm at nowadays, and which may not necessarily be specifically on mental health, but you've both hit on themes around prevention and early intervention. And that is a huge issue in our healthcare system today. Let's talk a little bit more about how we can do a better job at that.
Well, I think the reason you're hearing what we talk about in kind of more general terms is that this is simply about how we want to treat each other. Okay, it's not about mental health care, per se. It's how we're going to dignify one another. When someone is sick, we respond. But we need that same sense of response to apply to when someone is mentally ill or has a substance use disorder. Do we respond in a like way? We don't. So those are more insidious attitudinal changes that we have. But just like with the civil rights movement, where you had to go through attitude changes, you could also change the law such that even while attitudes lagged behind, the law wasn't going to lag behind. And it's enforcement of law that actually helps change attitudes by changing expectations. So I think this is a historic opportunity for us to make these changes. '64 Civil Rights Act was passed, but then you need the Voting Rights Act as we're coming up to the 50th of Selma. Then you needed the fair housing, fair employment. There are future battles to ensure that we live out the promise of treating one another as sisters and brothers, as we would our family and our friends. So that is the real value that we have at the basis of what we're talking about.
But let me just say, I think one of the differences also, of course, is stigma. I think the stigma that still too often surrounds mental disorders in this country is, in fact, a major barrier. And we have to work together to overcome that. You mentioned veterans. We see patients in a homeless care setting, and 60% of those patients are veterans. I mean, these are people who fought for this country, and many of them, of course, have committed suicide in the past. We're trying to make sure that people like that have access to quality mental health services. So I do think there's a difference, and that's why it's important for us to better integrate mental health care into the overall health system. Now, remember, people with mental disorders have chronic disorders of other kinds. They have cancer, they have heart disease too, and all of those things. The life expectancy in general of a person with severe mental illness is 25 years less than the rest of the population. So, you know, there is a lot of integration to do here, but I also think we need to work at the community level to change attitudes, to remove the stigma that still too often surrounds mental disorders.
There's also a lot of discussion nowadays in healthcare around technology. There's so much new technology coming out. The power of data analytics nowadays, when you think about whether it's population health at one end or precision medicine, which we need to get to today as well. So all of the technology, the mobile apps that are out there, do these offer opportunities to improve the mental health of our nation at a potentially lower cost? Do you see that in the new technology?
Well, we're looking for the triple aim, and that's to treat people in the most effective way where they are. And data can be a big resource for us to be able to do that. We started this organization called One Mind for Research, and it's to really coalesce all the research so that there's a common appreciation for the underlying mechanisms that underlie many mental health disorders. So the concept is, let's throw in together, work on this together, and get the results together in a more expedited way by collaboration as opposed to by all being fragmented, which tragically happens not only in the neuroscience field, but also in the delivery of mental health field, such that you treat addiction over here and mental health over here. But this is all silos that have been really exacerbated by funding streams by the government. So what we hope to do with our policy is really advocate what we know already works, and that is a holistic approach. And technology can be a big asset to our being able to do that.
From a clinical perspective, doctor, what do you think you can do with big data and technology that's out there today?
Well, I think Patrick's response to that is really important. But let me say that in clinical research, of course, we are really concerned about how do we integrate mental health care into the overall health system. And how do we improve diagnosis, early diagnosis? We've developed a kiosk, that allows patients to be screened for depression, for example, and expedite treatment. We need that. We need it at the community level even. So we have opportunities there. We also have research going to how do we integrate the culture from which the patient comes or in which the patients live into their overall treatment. And we have a project there. I think my deputy is here too. They're watching me very closely here. But
We're going to call on them later, see how you
Dr.
did.
Keisha Holden is leading a research project in which we are trying to integrate culture and the culture of care into the overall care and well-being of patients.
I would also just think, talking about veterans, and many of them have to travel long distances to access care, and even the ability of telehealth consults. There was a recent announcement by a famous television doctor who is going to be a part of a business offering psychiatric consults over telemedicine and even over your telephone.
telemedicine is going to be big in this community too. We have a shortage of providers. We need to address that. Technology can help leverage those that are currently out there so that we can reach more people. But also, cognitive behavioral therapy. It's the defined therapy that's most effective. We just need to get it out there. Much of this can be done even with new platforms like gaming. Who could imagine our returning veterans, their virtual Iraq, where they get to go back, address their fears and triggers, and deal with it in a setting that allows them to cope with their post-traumatic stress. Those lessons learned for our returning veterans can be applied to the public at large. And that's why technology provides tremendous opportunities.
Yeah, and CC, you mentioned that there are 2 million people in this country with mental disorders who are in jails. What we do in this country, of course, is we dump our mental health problems on the streets of America, so they end up in jail or in a homeless shelter or, unfortunately, often in coffins. So we dump. Now the question becomes, how do we make sure that people who end up in prison get the quality of care? And the use of technology is part of that answer. It is a way of providers being able to deal with patients even when they're not necessarily face-to-face. There may be a physician assistant, a nurse practitioner, others with the patient, but it allows a clinical psychologist or a psychiatrist or whatever is needed to really directly deal with that patient. That technology is also important, and it's critical technology. Many people end up in jail because they have mental health problems. And yet all we know how to do as a country, we know better, but we don't act differently, is to put them in jail. So fortunately, we have now several judges throughout the country who will sentence people to mental health care settings as opposed to jail. And hopefully that's going to increase and improve as we treat people with mental disorders with more dignity and care.
There's great models like Dr. Satcher mentioned out there where we're reducing the cost on the taxpayers, which is an overburden because so many people end up in jail, as Dr. Satcher said, instead of in care, and how miraculous that we can provide care and reduce costs. I mean, this is a win-win, which in this town, they love those kinds of wins. So it would seem to me we can put those proposals on the table, amplify them, because this isn't new stuff. Show where some best practices are going on around the country. Miami-Dade is an example where they've really reduced the jail beds and also provided intensive case management, and for the rest of the public safety, improved dramatically public safety in the process. This is something that's long overdue.
I want to remind anybody who's watching us online via webcast, you can send in questions because we already have a couple from you, and we'd like to get some more in. I'm glad that you mentioned the gaming example with the veterans, because I'm not a gamer myself. I used to think it was pretty trivial, but we've seen very similar results in pediatric oncology care. And so I think that, again, now as there's more and more study actually coming up with the data on the results of these different types of approaches to care.
That's right. That's right. And from the babies on through the rest of life, I mean, in developmental disabilities, and my aunt Eunice Kennedy Shriver has started Special Olympics, transform attitudes towards people with intellectual disabilities. We need to do the same in the area of mental illness. And so that's our challenge. And with young kids, being able to, we can mediate their autism with many technologies that have the ability for us to engage kids in therapy, through these cartoon characters, where it wouldn't be possible through a therapist because of the facial recognition issues. There's just tremendous opportunity for our senior citizens who are living longer and need challenges that they can solve through remote devices. It's a terrific opportunity to only bring care when it's needed as well. So there are these technologies, home buddies, where they support visiting nurses, channel care where it's needed. That's the other aspect of devices. It's not just the delivery, but it's the identification of when there might be specific challenges so that the resources meet the challenge and aren't just spread out in an indiscriminate way without real effect in terms of how they're being spent.
So we are here in Washington, and the president did just give his own State of the Union address recently. We've now seen the administration budget. Is mental health on the agenda in this town?
Well, I think you can tell from the President's State of the Union what are the big issues. And of course, we didn't hear about mental health really addressed in the State of the Union. And I think that is challenging because, as Dr. Satcher said, what's more important to our overall health than our brain health, our cognitive capacities, and our emotional health? I mean, these are things that, as you know, through your research, affect the workplace, affect our criminal justice system, affect the rest of healthcare. And so we really need leadership. I had the opportunity a couple of years ago to rededicate the John F. Kennedy Special Warfare Center in Fort Bragg, North Carolina. And there they refer to mental health as a force multiplier. I mean, how powerful that the military sees investing in brain health as key to our competitive edge as a military. Why wouldn't we take that lesson, apply it to the rest of our country and say, for us as a nation to be competitive in a global economy where we're challenged in terms of our partners around the world, where we wouldn't put an investment in brain health because it's going to help give us that competitive edge against our competitors around the world. That's the kind of framing we need from the President of the United States.
And I must say, I think the President's commitment to research on the brain is very important, and some of my colleagues on the commission, it needs more support, more funding. I was disappointed that it wasn't mentioned. And other things that relate to what we're trying to do here. I had the opportunity to work with Patrick's Aunt Eunice, and as you know, we have the National Center for Child Health and Human Development. Really, she's primarily responsible for the fact that we have that institute at the NIH. We need more research, more neuroscience research generally at NIH and CDC and other places. We've got to push for that. The prize is great if we can get there.
But you mentioned the brain research. Correct me if I'm wrong, but the U.S. proposal is fairly small compared to, say, the U.K.
Well, it's small also relative to the challenge. When you look at the population, autism, and Alzheimer's, and addiction, just to mention a couple of disorders that start with A. I mean, if you, if you start going down the list.
We'll be moving on to B later today.
We'd be here all afternoon. I mean, it's just shocking that this isn't a bigger part of our national agenda. And I don't fault the President because he's not getting the message, because Congress isn't getting the message, because the American people don't know what the message is, because we've been so siloed by our diagnosis as opposed to thinking, how are we all in this? And whether your child has autism or your parent has Alzheimer's or your brother or sister has addiction, it's all the brain. It's the brain. It's the brain. And so I think we need to get our attitudes adjusted so that we're all in this together, because the treatment of care often parallels. The supportive care for someone with dementia who's older or a child with intellectual disabilities is the same kind of community-based wraparound support services that's helpful for someone with a mental illness or addiction. We're not that far off from what we all need. It all needs to be implemented together. So you're not going up to the hill and saying, this is the Alzheimer agenda, this is the autism agenda, this is the schizophrenia agenda, this is the addiction. We're all in this together. So it's a real, as Dr. Satcher has pointed out, a collaborative effort, because the politics will affect what ultimately is reflected in the budget as it was released yesterday.
Right.
And a message I want to repeat, because it's really important to what Patrick said. What we found is that when you improve the care of patients with mental disorders, you actually save money. It's less expensive to treat people with dignity and quality and to get them involved in a continuity of care situation than to have them running back and forth, even only when they have emergencies, to the emergency room, but also to have them end up in jail, 2 million people. It will save money in the long run. It's really penny wise and pound foolish not to adequately support this research.
And I would think that employers then would be a receptive audience for that sort of message. If I'm not mistaken, depression is one of, if not the largest healthcare expense for most employers.
Well, it's interesting, when we were working to pass the parity law, people were really, oh, it's going to cost us more and this and that. But you know who our biggest supporters were? Wall Street. I mean, the very people who are more concerned with the bottom line than anything else. I love Dr. Satcher's emphasis on human dignity and protecting the human person and treating each other with dignity and respect. Those are great, but the bottom line is, in a town which just looks at the bottom line is there. This saves money. So whatever it takes for whatever audience, the message is there that this makes good business sense. Workers are going to be less absent, more productive. And the testimony to that is the fact that they offer the most generous benefits where the most human capital is involved in business. And I should think today, with our economy shifting to more intensive human capital economy, we ought to be putting more investment in mental health than ever before, since more of our competitive edge is dependent on whether someone's able to function optimally in the workplace.
So let's get into the legislative sausage making for just 1 minute here. There is a lot of interest right now in this town in the 21st Century Cures legislation. Is that a potential vehicle for some of what you both are talking about today? Or is there something in particular you'd like to see in that legislation?
Well, the key aspect here is that we're in it to win it. And the notion that, we're just talking about precision medicine for cancer and cardiovascular disease and not talking about it where it's going to be most influential, and that's in brain health. This is the most complex organ. Our medicine needs to be, by conclusion, the most precision, because there's so many aspects to these illnesses that are personal to the individual who's suffering from them. So really, this is the transformative time that we're living in that respect. So 21st century, there's several pieces of major legislation that are being proposed on the Hill to address the crisis and mental health in this country. We need to give all of them the attention that they deserve, but we also need to articulate the big picture, because what often happens is we all go down various back roads because we fail to understand what the eyes on the prize is. And the eyes on the prize is, let's keep in our first and foremost what's going to help all of us together, and what's the guiding principle for us to support or oppose particular pieces of legislation.
Mm-hmm. Before we turn to our audience, I do already have a couple of questions that have come in from folks online. So maybe I can read those, and then we'll turn to our audience here, if I can pull up those note cards where they're written down. This one came in a little earlier this morning from Maryland. Maggie in Maryland, we hope you're still watching. Doesn't parity mean insurers can't require pre-authorization for mental health services if they don't for other services?
Exactly.
And
so
this sounds like somebody who maybe has had a frustrating experience.
That's right. As I said, the law is there, but we have to put the law into practice. Part of what we need to do is monitor how insurance companies evaluate and make those decisions concerning care. This is known as medical utilization review. So everybody's been subject to it. We just need to make sure that there is no more onerous burden on those with brain illnesses as compared to those with illnesses of any other organ in the body. That's simply put. It doesn't mean that parity is going to be the answer to all of our challenges. It just means do not erect any higher treatment limitations in brain illness as you otherwise would in other physical health. And that would put us in with some powerful forces, cancer, diabetes, heart disease, in together taking on how we're going to make sure our healthcare system works better. But what we first need to do in the area of mental illness and substance use disorders is just come up to the same level of urgency in terms of the treatment of care as the other physical illnesses have.
And this is really one of the key components of our partnership. And we hope to travel around the country and meet with legislators and community leaders, patients and families. The goal is to make sure that these great laws that we have on the book are fully implemented when it comes to the needs of patients and families.
And speaking of barriers, I'd love to get your perspectives on a trend in healthcare today, a very significant one, and that is the rise in high deductible health insurance plans. So you now have more than, I think, 42% of people that are in employer-sponsored health insurance plans have a deductible of $1,000 or more. Do you have concerns that we're going to start pricing people out of care if they're in these high deductible plans?
Well, the premise of your question answers your question, too. I think it's absolutely the case where everybody is on the chopping block here. What we need to make sure is that insurers who have the fiduciary responsibility to deliver care are also being held accountable. And what I mean by that is there's a fiduciary responsibility they have to get the best care of the person at the right time. And that may be in their interest when it's a risk situation where they're underwriting the risk. But in many cases, like these ERISA plans, they're just the administrators of the plan, which means they don't carry the risk. And therefore, they have no fiduciary interest in really getting the best deal for the consumer. That's a thing that's really not understood much in healthcare, is that we need to get the insurance industry to really partner with us to come up with ways that we're going to solve that problem. Because everyone knows that insurance companies brought kind of ACA, so to speak, to the fore, but that means that they can't be let off the hook in terms of the implementation of the ACA. And that means that they now need to be part of how we're going to reduce costs overall in a way that's equitable, going back to the earlier comment. So that's a big challenge.
No, I agree. I think we've got to find ways to both, well, let me say we've got to find ways to incentivize the right behaviors. I think the Medicare rules related to meaningful use, for example, that actually rewards providers for the use of electronic health records, that's a direction we've got to keep going in. We've got to find better ways to incentivize the right behavior at the same time as pushing these policies and implementation. How do we actually reward those who go out of their way to make sure that it enhances patient care and not diminish it?
Okay. Another question came in from Lynn in Canada. And Lynn asks, what can be done to educate family doctors in relation to youth mental health? And her observation here is that they're failing the 16 to 24-year-old demographic in particular. And I'm glad that Lynn mentions that group, because that's often where we're seeing a lot of these tragic shootings nowadays.
Well, I have a lot of affinity for family doctors. Let me say that first. The first problem is we don't have enough of them, and we need to really do a better job of training primary care providers in this country if we're going to really open the door to care to more people. But then we've got to do more of what we did initially but could run out, and that is really incentivizing the care of the poor and incentivizing people for practicing in rural areas and underserved urban communities, and incentivizing preventive services. Again, I think the Affordable Care Act is some tremendous opportunities there if they can be implemented, and that's our concern. So I think we've got to make sure that we train more family providers, reward them for doing what we need them to do, and to really continue to appreciate the importance of having a physician in rural areas, in urban communities, so that wherever you are, you can get access to quality health care.
Well, in fact, in healthcare of the future, as we move from a volume-based system, fee-for-service, to a value system, those family care doctors are going to be so critical, because they're going to help contain some of those costs.
Your point is so important, and let me just say, when we talk about volume-based system, physicians, providers now get rewarded often for the number of times they see a patient. You have a patient with hypertension, diabetes, you bill for every time you see them. The Affordable Care Act says value. We're going to bill for how well you control the blood pressure and the diabetes. Major step forward. It's got to be implemented.
But over 70 to 80% of mental health medications in this country are prescribed by primary care physicians, not by psychiatrists.
That's exactly right.
So the key is, how do we build a collaborative care model? Again, the evidence base is you provide supports for the primary care physician with expert referrals and so forth, helping them guide their decision making. You maximize the very few psychiatrists you have and give them the leverage to make an impact with their colleagues. We also need to train in medical school, obviously incorporate as part of the core curricula treatment of mental illnesses and substance use disorders, such that it isn't a late identification and diagnosis, because it really is true. An ounce of prevention is worth a pound of cure. And going back even earlier in their life cycle, it's really the nurse-family partnerships, these standards where we show if the parents are at risk, you can be sure the children are at risk. We don't need to be spending the same on everybody. We need to be spending our resources where they're going to be doing the most good. And we know where the critical spots are, and yet our dollars are not following it. And the return on those dollars is enormous, as all those studies like the acute and adverse childhood experience studies demonstrate. Early is the key to really mitigating the disability and burden of these illnesses.
Yeah, in public health, Patrick, we say that an ounce of prevention is worth a ton of cure. and we stand behind that.
Exactly.
Okay. Do we have some questions from our audience here? And we have microphones that are coming up. I see one here in the second row and then over on this side next.
Hi. Mary Woolley with Research America, and thank you so much. Thank you for your leadership, gentlemen. Let me just start by saying that. Talk about force multiplier effects. Here it is, right here. So my question, though, is how do we go beyond the people who are currently speaking out, speaking truth to power, talking about what needs to happen next, so that we can get past that status quo thinking, if that's the right way to explain it, that it really is an irresolvable problem. Dr. Satcher, as you were quoting John Gardner on that, so that Americans, I'm struck by the insight that Americans aren't getting the message so that they can then deliver it to their elected officials who aren't getting it separately. What advice do you have for all of us? How can we help? Can we make this happen?
Well, first, Mary, thank you for your leadership of Research America and the tremendous impact you've had on research funding at NIH and CDC and other places. We've got to do a better job of educating the public. And I mean, children in school, churches, we've got to take advantage of opportunities to engage the community. Our president, Dr. Montgomery Rice, talks about our engagement with community. It's really key that we do a better job moving forward at engaging the community in this. And that's one thing we hope to do as we travel, not just to talk to legislators and others, but to really engage leaders of churches and religion, basic legislators, parents, so that, in fact, we can have an educated community. And if we can get an educated community on these issues, we can get the right policies ultimately in place. Now, we do depend upon policy leaders to be, policymakers to be leaders too. But believe me, when people are running for office, it really pays to have an educated electorate.
Hands over here. Microphone.
Ron Manderscheid, County Behavioral Health Directors. Thank you both very much for all the wonderful work you're doing. My question, how can we from the national organizations work best with the new center?
Okay.
Well, thank you, Ron. Frankly, we're going to learn lessons learned, not just what Washington thinks or does, but from out in the communities across this country where they're actually showing and demonstrating how reorganizing budgets, you know, they had this famous phrase from, you know, over 30, 40 years ago during Watergate, follow the money. If
always served me well.
we truly followed the money and saw where all the costs were, and we're able to back up and reallocate those dollars where they're going to reduce the overall burden and cost, it would be a no-brainer for decision makers, both on the county and the state level as well as the national level. Our biggest impediment is that our budgets and our budgeting process does not include all the necessary services and equates them to the cost such that we can really see the sum total of the benefit that can come from aligning various both medical and human and social services to the need that that particular person has. So in this county down in Miami-Dade, for example, they have reallocated this recidivism within the prison, the jail system down there, into intensive case management. They've dramatically dropped the cost of the jailing of individuals and all the concurrent criminal justice costs. And they have reallocated those dollars to more support services, which again is reducing more of their costs. But that has only been because of the leadership of a fellow by Judge Leifman, who's gotten the whole budget together, and he's shown everybody, I'm going to save you this much, but you got to throw in with me. Now, as we're tackling big budgetary problems here in Washington, We need the CBO, the GAO, to start looking at these holistically, because SSDI is on the rise, all these other costs, and it's just because we failed to take the whole costs into account and reallocate the resources, which frankly under our budgetary rules today isn't possible, Ron. But that would be the best way for us to get the biggest effect.
In fact, in healthcare, 5% of the population accounts for 50% of our healthcare spending. They're often called the super utilizers,
Yep.
and many, many, many of them have exactly behavioral, mental health issues, addictions, et cetera. So it really is follow the money. I saw another hand in the front. Oh, Ron, a follow-up. All right. He's got the microphone.
No,
so.
separate question. David Gastrin for Treatment Research Institute in Philadelphia. The content so far has really focused on holding payers accountable, and that's a critical goal, and TRI is participating with the Kennedy Forum to help investigate that that is the case. But I think there's a need for more sophistication in our look at the problem and the stigma, because it's not exclusively old attitudes and legacy, it's also the performance of the treatment field and the caring professions and their need to adopt scientific approaches that have been in existence for dozens of years now, and it really isn't available consistently throughout the country. We have a balkanization of treatment approaches. We need to defrag that treatment field. And so I'm very proud that the Kennedy Forum's second objective, after accountability of payers, is accountability of providers.
That's great.
Well, thank you. And Tom McClellan, as we all know, has been such a champion in the area of addiction medicine. He has been so good at aligning what we do for diabetes, for asthma, and say, why aren't we paying for those kinds of chronic care management in the way we treat those with mental illness and addiction? So there needs to be an alignment, but there also needs to be, our expectations are such in physical health that we would demand no less than the evidence base. But in mental health, that level of literacy and expectation is not where it needs to be. And TRI, Treatment Research Institution, is really doing a great job at pushing the envelope and disseminating what those best practices should be.
And I just want to say, I agree that we need to hold providers accountable. I also believe that we need to incentivize the right behaviors. If we want a behavior to occur, we got to make sure that people know you get rewarded when you do it right. And we all benefit when that happens. I pointed out that we've already demonstrated that you can reduce costs by 40% while improving the quality of care.
We're going to go over here and then come to this side.
Thank you both for all of your efforts in this area. I'm Dr. Renee Binder. I'm president-elect of the American Psychiatric Association. I represent 36,000 psychiatrists. And we are working on this as an association, but I wanted to ask both of you, what would you tell a family member or a consumer if they felt their insurance was discriminatory?
One of the things that we're going to do is work with the Parity Implementation Coalition, which we already are working with the APA, and thank you for all of your and tremendous support for this effort, and that's to get a toolkit online for families to be able to navigate the cumbersome process of filing an appeal when someone feels that they've been denied wrongfully. Part of the problem is you've got the effect of not only being denied care, but then the inability to advocate for yourself if you're in a crisis. And if your family member has to be doing it for you, and often they're overburdened because they're so busy trying to take care of you. So we really need to lighten the load on those families to allow them to get that care that their family member needs. And again, I think in the past we've understood that these are stigmatized illnesses, so no one's going to really put their hand up and say, I was denied, because people feel it's enough of a burden to even ask for the care to begin with. So we can't make it more difficult. And unfortunately, the appeals process is very cumbersome, and we need to really clarify and expedite the ability for people to get those appeals done. So thank you for that question.
I have time for
Could
a
I
couple.
just,
Yes,
I just
please,
want to
Doctor.
congratulate you on being the head of the American Psychiatric Association, and also to express my appreciation. I had tremendous experience working with the APA when I was working on a report on mental health. And of course, that's become an ongoing relationship. And I know you have also suffered from some of that stigma that we're talking about. So I think we're really in this together in terms of trying to overcome that so we can provide the kind of quality of care that I know you're committed to. So thank you.
Okay, over here, microphone. Great.
Good morning. Andrew Kessler on behalf of the International Substance Abuse Counselors. We represent over 45,000 credentialed substance abuse counselors in the United States and internationally. What we saw in the president's budget yesterday was a new commitment to opioid abuse with a request for $100 million in new funding for that. And I think many people in this room are very pleased to see the fruits of their labor come to such fruition. But what we see on Capitol Hill is often attention paid to a drug du jour. Right now it's heroin and prescription drug abuse. 10 years ago, all anyone on the Hill wanted to talk about was methamphetamine. And 20 years before that, all anyone wanted to talk about was crack cocaine. And what we do from a policy perspective is talk about whatever the media has portrayed as the largest problem. Yet in the end, we have not really seen much movement in terms of treating the disease of addiction. We need to treat that one disease. How can we leverage this current interest in opioid abuse, which is phenomenal and an interest level many of us thought we would never see coming from Capitol Hill? How can we leverage that interest in one particular kind of addiction and abuse into a solution for the overall disease, just as people who represent breast cancer have contributed to overall cancer research or other diseases?
Well, first of all, I'm a person who's living in long-term recovery, and it's because of the support of my beautiful wife and my friends in recovery, and none of us can do it alone. And the notion that there's just addiction to one thing, you know, in my case, it didn't matter what it was, and that's what we have to change our attitudes towards. We often think of, I remember when Matt Lauer was asking me a question, he says, tell me the drug, and I said, I wish I could remember which one it was that you're asking about. The bottom line is it doesn't matter what drug it is, it's the fact that as a whole, people are seeking to end the feelings that are causing them to self-medicate, and so that people choose different substances. The bottom line is that we all share the same challenge of overcoming this threefold illness. And it's a physical allergy, a mental obsession, and a spiritual malady, in case you're not in 12-step recovery. That's how we... But, you know, it takes a holistic approach. So I love, as you pointed out, this is the urgency right now. But we need to be more holistic in our thinking, and that's what we're trying to do overall. And frankly, mental health contributes in many cases to someone's substance use disorder. So leaving that out of the question and siloing the funding is what often gets us into this arcane situation of fragmentation of care.
Well, I'm not surprised we've run over time, but, and I can see there's a lot more dialogue that people would like to have, but I would love to just ask each of you for a closing thought in terms of you have this group here that cares so much about this issue. What's your ask of them?
Well, you know, I borrowed my family name, which has certainly helped me a lot in my political career, to this cause, because President Kennedy really said it best when he said, the mentally ill need no longer be alien to our affections. Doesn't that capture the thought? Alien to our affections, or he said, beyond the help of our communities. He wasn't saying beyond the help of our psychiatric hospitals, our psychiatrists, psychologists, our peer specialists. Our communities, meaning we all had to be in this together. This isn't just one person's job, it's all of us working together. That was powerful. It was the same year that he spoke on civil rights. And the other thing he did, which everyone knows, is the moonshot. But the moonshot took everybody working together for a collective goal. And in brain science, we need a race to inner space, not outer space. And One Mind for Research, which is being led by four-star General Pete Corelli, is seeking to do this with urgency because this is a national security issue. Our veterans are dying every day because of suicide. It is shameful in this nation that we're not moving to treat their wounds of war as urgently as if they were dying on the battlefield from a lost limb or any other type of physical injury. So this is what we need to have guide our energy, is the notion we've got our fellows, brothers and sisters, but we have our American heroes, our veterans. And that ought to be the tipping point for our Congress to act, because this is a bipartisan issue. And this needs to be, and it is. It affects all families in America. And that's what we need in order to get the change politically that we're seeking.
Well, I agree. Amen is what I should say. I do want to remind us that this starts with mental health. So none of us can take our mental health for granted, and I think we often do. What is mental health? We define it as the successful performance of mental function such that one can be productive in his or her work, one can develop and maintain positive relationships with other people, beginning with families. Mental health is also the ability to adapt to change in our lives and to deal with adversity. You know, after Hurricane Katrina, depression went up from 10% to 30% in New Orleans. So none of us, so we're not talking about other people's problems. We're really talking about the fact that none of us can take our mental health for granted, and we ought to work very hard to make sure that we have a system in place that takes care of everybody who has mental health problems. I think that's the key. Just as things go wrong with the heart, the lungs, the kidneys, and the liver, things go wrong with the brain. They always have, they always will. The only question is, how will we respond? And I hope that the answer to that is that we will rise up and treat issues related to the brain as we do, and better, in fact, because if we can bring together all of the components of our body in a very professional way, we can all move forward together.
Dr. David Satcher of Morehouse College, former Congressman.
Morehouse School of Medicine.
School
there
of
is a Morehouse
Medicine,
College.
pardon me.
Morehouse School of Medicine.
Thank you. I knew we'd get caught on something before I got out of here
You did great.
safely.
Thank you, Cece.
Former Congressman Kennedy, the Kennedy Forum, to all of you, thank you and congratulations on your new effort.